And we're back talking with Dr. Todd Brookover. Doctor, before we go any further, you said something to me about the odds of every man out there having prostate cancer. And I think it was something along the lines of, if you're 60, you've got a 60% chance, 70 or something. Can you break that down for us?
Well, roughly that's right. I mean, those are incidental cancers. Those are not all clinically significant cancers, but there have been autopsy studies done which will, when you correlate the percentage of finding a focus of cancer in a prostate on autopsy to the patient's age, it's roughly 60% at 60, 70% at 70, and so forth.
It's amazing to me how few people I know who've gone down this road, and I just wondered, are they refusing to have it checked? Are men just leery of saying, look, I want to be checked for prostate cancer?
There is some of that. There's also some information out there that is a little bit controversial that would say that you don't need to check PSAs because it's not helping people. Mm-hmm. That's a very complicated issue. There's no question that checking PSAs saves lives. The question is, how many PSAs do you have to check to save one life? And how much? It's a financial discussion mm-hmm. more than a medical discussion.
It would seem to me that the way our relationship started, as I look back on it, your attitude was one of establishing right off the bat, because you did the same thing to me in our first meeting that you did on the phone. You said, look, Sam, this is not an aggressive form.
Right.
To put my mind at ease. And I started then to hear you. How many different levels are we talking about here? Are there just two levels, aggressive and non-aggressive?
Well, it's a spectrum. And you know, when you get the diagnosis and you go in to discuss treatment options, the options that you mentioned a minute ago are basically it. However, you have to look at a few factors to come up with a well-educated decision. Ultimately, the decision is the patient's decision, but they are guided by their physician mm-hmm. usually in making that decision. You need to look at the cancer. Is this an aggressive cancer? Is it a threatening cancer? But equally as important, you have to look at the patient. You look at comorbidities. Is this guy healthy enough to go through an aggressive treatment? Is he going to be likely to suffer side effects mm-hmm. which affect his quality of life? One thing that's unique about prostate cancer amongst all the cancers we deal with is that it's a chronic illness more so than an acute event. And so if I have a patient sitting in front of me and he's got a cancer that's probably not going to kill him, or if it does, it's going to be 20 years from now. Mm-hmm. And I give him put him through a treatment that interrupts his quality of life and makes him miserable, have I helped him? You know, I'm not sure that I have. And so you look at how aggressive the cancer is, you look at how healthy the patient is, and then I kind of get a feel for what type of patient am I dealing with. Mm-hmm. Is this somebody who is going to go to bed at night worrying about his cancer and wake up the next morning and think about it first thing? If he is, then he needs to treat it. And because your cancer was on the edge, it was in order to realistically go into an active surveillance program and that be a good decision, you need to meet 3 criteria. Less than 3 biopsies positive, a PSA of less than 10, and a Gleason score of less than 7. Well, you met 2 of those, and your PSA was just a little bit over 10. And so active surveillance was not out of the question for you. Mm-hmm. But I got the feeling in our discussions that you weren't going to do well with that. You were going to worry about this.
Oh, I'm a worrier. There's no question.
Well, I think that's a factor that has to be taken into consideration. Mm-hmm. It can be a focus for depression, a focus for anxiety, and it can, in and of itself, it can interrupt your quality of life.
Mm-hmm.
even without treatment.
If my wife were here right now, she would have said, "That's him, that's him."
Right.
You know, so you nailed it. You nailed it right on the button. It has to be a hurtful thing for you to have a young man come in seemingly healthy, with his life to live, with a family at home, and you've got to tell him, you've got a very aggressive form here, and I'm not sure on the prognosis. That's happened, hasn't it?
Oh, many times. Many times. And that is difficult. It's also difficult to see someone that has had treatment and they've had disturbing side effects, and it's ruined their quality of life. I've seen that too.
You know, when I first went in, they're going to see here in just a second, for the treatments, the radiation treatments, I was absolutely amazed, first of all, at this huge machine and all that it would do. And they wanted me to do what? Get in there with it, with doors this thick? And I'm going, whoa. But I walked in and popped up on that table, and away we went, as you'll see here in just a couple of moments. I was pleased with the outcome, and if you don't mind, I'm going to go ahead and take the viewer in to take a look at it. And I want to invite you to come along as we go through a simulated visit through radiation. I don't want to give you a false impression that this is the real thing, but the folks where we went, and you'll see all of that in just a moment, were kind enough to open their doors to our camera and allow us to come in so that you at home might get a first-hand view of what it's like to go in for radiation. Take a look. This would be the next phase of my journey, the Prostate Cancer Institute. For the next 45 days, the staff here would guide and support me through the routine of daily radiation therapy. The bell was there for me to ring after I finished my treatment series. So, as I counted down each treatment, I always glanced at that bell. That came to be a symbol for me. One of the first things I noticed was the heavy door that led to the actual treatment unit. On this day of video work, the staff agreed to allow photographer Daniel Murphy inside so we could give you an idea of how these daily treatments are handled. No radiation was involved, but the steps are the same. Ordinarily, a reporter always uses the first names of folks involved in a story, but in this instance, we'll be using only first names. Outside the big door, Michael and Chris ran the unit while I was on the table. Betsy, the chief therapist, was on hand to explain.
All the patients have tattoos on their skin on the outside. It's just a dot, looks like a little freckle. We line up the lasers that are in the wall to those tattoos, and we step outside and take an x-ray and look at you on the insides, look at your bony anatomy, and then if you have gold seed markers, we look at those and line your treatment up even more precise. And then once those two things are done, the treatment begins. And the machine treats patients at different angles. It'll move to an angle and go on and off, and then rotate to the next angle and give the radiation. And then once the radiation's off at that angle, we move it to the next angle until all the radiation has been delivered. Just like a doctor writes a prescription, like you say, like antibiotic, the radiation oncologist writes a prescription for the patient to get a certain dose in centigrade, and then after they do all the calculations and they decide what angles for the radiation to come in at, then that centigrade is delivered over that many angles. Here at PCI, we have a Varian linear accelerator. It's an IX. We treat all of our prostate patients with 6X energy, and they typically get anywhere from 180 centigrade to 200 centigrade a day.
There was never any pain or even mild discomfort resulting from the treatments, and with a nod to Michael J. Fox and his Back to the Future franchise, I referred to the machine as the flux capacitor, and over the days that followed, it became less and less intimidating as it focused on my cancer. My morning appointments left me the rest of the day to do anything I wanted, no restrictions. My goal, finish the treatments, kill off the cancer cells, and ring that bell. That bell became a major target for me. But I have to say, before we walk away from that video that you just saw, the folks that took me in, that stayed with me for the 45-day period that I went through those treatments, opened their doors, their hearts, they treat you as family, which really enables you to face what is coming and to deal with it. And I have to admit, Doctor, it helped my attitude 200%.
I'm sure.
Now then, before we go on, and at some point here, I'm going to ask you about my prognosis. And I want you to be perfectly frank about this because my wife's watching too. We'd both like to know. How many, and I don't know how to curb this question, what are the odds for men out there that have no history of cancer in their family? In other words, do we even know what causes it?
No.
No reason, a rhyme or reason to it?
No. There's clearly a subset that is familial, but there's not, like with lung cancer, smoking as a risk factor. Mm-hmm. There's nothing like that. It's interesting, though, that if you look worldwide, there are some areas that have high rates of prostate cancer, and some areas, like Japanese men that live in Japan, they don't have a high rate of prostate cancer at all.
Really?
Very low rates. Japanese men that move to the United States and live here for their life, they have a higher risk of prostate cancer. And so that would indicate something environmental or dietary. Mm-hmm. But as far as specific risk factors for prostate cancer, there really aren't any.
That's an amazing observation, and quite honestly, I have heard other discussions. In fact, I saw an article in Smithsonian Magazine not too long ago that talked about the importance of diet, and then that recent announcement that I'm sure you've heard it, that bacon and too much beef of any kind can...
Well, there's no question that a high-fat diet is obviously not healthy, but it does increase your risk for just about any type of cancer.
You've been checked?
Have I been checked?
Mm-hmm.
Yes.
So you're okay?
I'm okay.
All right. We got about 2 minutes, and I want to ask you point blank, what's my prognosis?
Your prognosis is excellent. At this point, it's greater than 80% chance that you'll never deal with this again. And the fact that in your particular case, your PSA reached its nadir real quickly, mm-hmm. and that's a favorable finding. And sometimes when you give the radiation, it takes up to 18 months for that PSA to reach its lowest point. Yours just dropped out right away.
It's almost like the radiation said, get back in the pickup.
Yeah.
And it did it. Well, I appreciate you coming in, taking the time out of your schedule, because I got to tell you, I don't know how you guys live with the schedule you live with, but I will tell you one thing that I witnessed when I was going in for treatment. I was flabbergasted to see men come in who were beyond apprehensive, who were just out and out frightened, not of the treatment, but of the diagnosis, what they'd received.
Right.
Men who'd lived lives of strength and productivity, all walks of life, who would come through those doors with a sentence handed down that they, in some cases, assumed was a death sentence. And it didn't necessarily have to be.
Right.
So it's very important we encourage men to step up and get this thing checked. Am I right?
Absolutely.
Thank you so much.
You're welcome.
And thanks for the outlook.
Thank you.
Appreciate all that. Ladies and gentlemen, that's all the time we have for this edition of Green Country Perspectives. I'm Sam Jones. Thank you for joining us, and we'll see you next time.